Hello, I'm Josh. This is Tom. We're from Summit Physiotherapy. We were supposed to be going live, however, due to some time constraints, we are going to be doing this pre-recorded, and my email will be attached to this, so people can email me any more questions should they have them. But we do have some questions here that have been collected over the week that we are going to answer, along with some common injury problems. Um, Tom has been a sports rehabber for quite some time now. I know I introduced myself a couple of weeks ago, but Tom, do you want to give us 30 seconds of who you are?
Yes, my name's Tom. My career started in football, so I did a little bit of work in professional sport for the first kind of 4 or 5 years. So working with people who are athletic and probably dealing with some similar problems to what you guys as marathon runners are dealing with. I've been at Summit for the last 2 or 3 years now, and again, seeing lots of clients in your position who are wanting to work towards a goal and build up without getting any problems. So yeah, that's just where we are today.
You also do strength and conditioning as well, don't you? Which there's a lot of crossover, but
Yeah, I think that's it's been one of those things that's becoming more and more popular now. I think runners are starting to notice that that's probably going to be a little bit of a magic bullet in terms of increasing the performance. So it's definitely something that's interesting for people who are looking to do the marathon times.
yeah, cool. And do you think that, just quickly before we move on to the questions, do you think S&C helps people to improve their performance by not getting injured or by improving their performance or both?
I think it's a little bit of both. I think in terms of research, I think improving the performance is something that we can definitely make the claim for. Injury prevention, it definitely comes into that, but we have to be a little bit careful with what we claim it can and can't do. But yeah, I think it's definitely got a place in anyone's program who's looking to do, a long distance then.
Yeah, cool. And we did touch on some of this stuff a couple of weeks ago for anybody that did watch this. So I'm just going to read some of these questions off my phone that we've got, and we'll just have a chat about them and see if we can give any general help. It's really difficult to give any specific advice to people on here because there's so many variables that we don't have to give you specific advice. So anything that you take from here, please don't take it as your medical prescription. Please just take it as general advice that you can follow and question and ask us questions about. The first one is um, how can we avoid how best to recover from shin splints and how to avoid them reoccurring? What do you think? Again, I know that you're going to say this is really difficult because everybody's reasons for them are difficult, but there are some general rules, aren't there, that we can apply to these things?
Yeah, I think the main thing is probably down to the training that you're doing and making sure that we're recovering from that training. So if we're getting shin pain and we're trying to run through a program, we need to make sure that we're not pushing it to the point where it's still becoming a problem in the days after that, where we're going to really start to see a compounding effect. So we need to have some way of judging whether or not we are recovering from what we're asking it to do. And that could be as simple as just judging the pain. How uncomfortable is it when we're actually running? Is it tolerable? Is it what we call acceptable? Or is it going a little bit beyond that? And then the other main question is how does it respond? So if we're waking up the day after a run and it's still sore, we're still feeling it walking up and down the stairs, then that might be a sign that we need to do something about it. What are your take on that, mate?
It's really similar. However, I use that scale of you don't want to be experiencing problems 24 to 48 hours after you've exerted yourself, or I use the it's kind of my own. It's not science backed. It's just from practice. Basically, it's just from practice really. That if your pain exceeds your tolerable threshold, usually put it for just as a baseline level until we get to know people and what's actually their acceptable level. If your pain is crossing that threshold and isn't reducing when you stop doing the thing that you do, then you know that we need to look at modifying what it is that you're doing, whether that be to come away from it or to just change your technique or to just do something else for a while. That's the only thing that I do slightly differently, but I do follow the same rule as you, as You don't want to be suffering for X amount of time afterwards. With regards to recurring shin splints, realistically, you're looking at two reasons, I think, why you're going to get recurring shin splints. Either there's some inherent area that isn't as resilient as you would like it to be. So you are training or exerting yourself past the capacity of that tissue. Or there's potentially some biomechanical reason as to why you are putting significantly more stress through that medial tibia, through the shin compartment, essentially. Any other reasons you could think of why somebody would get recurring shin splints as opposed to a singular bout?
No, I think I'd agree with what you said, really. It's basically telling us that area of your body is not capable of dealing with the loads that we're putting through it. So we can address that in a couple of ways. We can either look if we can maybe put a little bit less stress through that. So like Josh just said, if that means we maybe tweak the technique slightly to take a little bit of pressure off that shin. Or the other alternative is to strengthen the area and to make it a bit more robust and resilient so that it can deal with higher training loads or higher forces or whatever that may be, really. That's something that when we do our gait analysis here in the clinic, that's one of the things that we can look at, possibly making some short-term changes to the way we move, or even the kind of sessions that we do, and just try and take a bit of pressure off that area. Try to settle down and recover, really.
Yeah, and when I'm seeing patients and we're doing technique modification just so that people can carry on with their training program whilst they're managing their injury or their problem, whatever it is that they've come with, one of the questions I get is, if I have to do this modification now, do I have to do this forever? What do you think to that?
From what we know up to this point, it doesn't look like it. And I think with any kind of modification is that they're only designed to be short-term changes. So we might ask you to change your technique slightly. In reality, you're probably not going to be able to maintain that for a whole run. But what it might do is it give you a little break. So that area that's uncomfortable, that area that you're getting pain in, by changing the technique slightly, we might just spread that to a different area and give it a bit of a break. So no, it's not. Chances are when the pain's gone and we've worked on doing some rehab and we've maybe worked on some things in terms of the way that we run, that we won't need to worry about that too much in the future. It's just making the change now and just giving it time to calm down, really.
Mm-hmm.
Yeah. Any kind of different opinions, Josh?
No, I entirely agree. I just think on top of that, got to take into account Newton's laws of physics, that energy cannot be created or destroyed. It can only be transferred. So to shift that load, energy and load are, whilst they're not the same thing, it's easiest to think of them as the same thing. You're kind of robbing Peter to pay Paul. If we change your technique, somewhere else has to take that load. So to do that permanently, you would probably end up with a similar issue in a different area. So I think to do everything that we do is in order to address that balance between the load that you put through something and its capacity to absorb that load. And that's something that we spoke about just 2 weeks ago. If you missed that, please go back and watch that, because I did talk about load and capacity and that model of how injury comes about.
Yeah, I think that's something that gets brought up a lot. We quite often get asked where people come in and they say, I know I'm a heel striker, is that a problem? Or I know I'm 4 foot, is that a problem? And exactly like Josh just said, it's not necessarily a good thing or a bad thing. It just means that forces are in different places. So take an easy example. If we land a little bit more on the heel, there's going to be a bit more stress on the shin. Whereas if we land a little bit more on the toes, there's going to be a little bit more stress on the calf and the Achilles. So it's all a trade-off. It depends what you're dealing with at the moment. So I think that's a really good point, mate.
Thank you. I'm sorry that we're rushing. It's just that we've got quite a few questions to get through, and I know that you've got a patient come in fairly soon. I'll just find the next one. What do you think of shockwave for the treatment of Achilles tendinitis?
I think it can be really useful. I think what we've found when we've used this on people so far is that if it's something that we've been struggling with for a long time and we've maybe tried going down all the normal avenues, doing exercises, doing stretches, putting heat and ice on, it can sometimes just give you a bit of a refresh. So basically what the shockwave does is it sends kind of little impulses into the tissues, and it stimulates kind of the release of things that help with healing. So it can give us a bit of a window of an opportunity really, just to try and get a response, try and get things to settle down, and then to also have a look at some of the previous rehab and make sure that we're just addressing it from every angle really. So yeah, it's a useful tool to kind of get you back to a bit of a baseline if you've been struggling with a problem for a long period really. What's your technique, Jeff?
Well, I said before you came on here, before we started recording, that you and I probably weren't the best people to do this conversation because many of our views are the same. Uh, I but I did want to. A couple of weeks ago, I probably sounded quite negative towards Shockwave, and that's not a true reflection of the way I feel about it. I do think it's a very useful tool. I have been quite historically pessimistic about it, but that's because I'm cynical about everything until it's proven that it's good. And I have been seeing a lot of really refreshing and surprising results by shockwaving people that have these long-term tendon problems. And it was my patients that convinced me that it was a useful tool. And the more I use it, the more I think that it's good. Now, I spoke a couple of weeks ago about the evidence being a bit wishy-washy. It could help, it could not. But that doesn't mean that I don't think it's a good idea. Because when we're looking at mending things in physio and in this field, it's often a case of, well, is it going to do any harm? And the answer with shockwave is, unless you have a very specific set of problems or damage to the skin in the area, then it's likely not going to do you any harm to try it. And if it's not going to do you any harm, then the benefit is more than likely going to outweigh the harm from trying it. So I
Yeah.
do think it's always worth. The more I think about it and the more I use it, the more I'm warming to it as being something that we use. But I don't think it's a solution by itself. I think that people who sell it to you as a solution by itself, I don't think that's very fair to you. I think in order to change a tissue, we have to create micro trauma, and we have to put a lot of stress through it in order for it to grow stronger. And I don't think that those shockwaves, whilst they bring a healing response, I don't think that they do that.
Yeah, I completely agree. And I think if you had to take one kind of takeaway from what we just said, it'd be that yes, it's very effective, but it's part of a bigger picture. And we still need to do the rehab. We still need to make that tendon resilient enough to deal with the forces that are going through in an event like a marathon. So yeah, I think it's something that can be really, really useful, but we've got to take it as part of a complete package really, along with the rehab and possibly some modifications to training if we've not got that and really dialed it.
Absolutely. And just to add to that, that is the same with any kind of thing that you've had in the past, whether that be ultrasound, shockwave, heat lamps, massage, anything that you found that helps. Now, I only bring this up because I've had quite a few patients that come in and say, oh, I've had this problem for years now. I have a massage and it usually fixes it. And from where I sit, now, your injury is your problem and it's your choice to decide whether it's fixed or not. But from where I sit, if you come to me and say, I've had this problem for a few years now, and this usually fixes it, then the thing hasn't fixed it. So it's often a case of, I get Achilles tendinitis and I have a calf massage, and it usually fixes it for a while. It doesn't. It just potentially relieves your pain, which allows you to move a bit easier, and then it settles down and flares up again. Now, the most important thing you can do in any injury or any injury prevention is load management, potentially load modification, training modification, and increasing the capacity at the tissues that are injured. So strengthening with a specific rehab program guided by somebody who knows what they're doing. And I didn't really make that clear a couple of weeks ago, but unless you can think of anything else, Tom, I think that is the most important thing that you can do to stop yourself
Yeah.
and to get better from being injured.
Yeah, I'd agree. Yeah, it's make sure you're doing all the fundamentals, and anything else that helps you along with that is going to be useful.
Yeah. So there's things that are wildly helpful, immensely helpful is a better word, but they're not a magic pill. Like, without the foundations, the house will fall down eventually, is what I'm trying to get at. Next question. plantar fasciitis that keeps returning. So that plantar fasciitis is the fancy Latin name that we have for a bit of inflammation on the bottom of your foot. It usually hurts into your heel. The answer to that is the same, without a specific assessment to find out what are your variables. The answer to that is the same as the Achilles tendinitis. It's you may need to modify your training for a while, allow it to settle down, put some ice on it. The shockwave could help get you out of pain in a much quicker time frame. And yeah, it's training modification and strengthening. Anything else that I've missed?
No, I think it's very, very similar to the last example, really, about the shockwave and the Achilles. So if this is a problem that's been going on for a long time, what we initially want to do is make sure that, well, first off, that we are targeting the right area. Well, secondly, something like shockwave might just give us an opportunity just to stimulate that tissue, and then make sure that we're strengthening it to be able to deal with what it needs to do. I think that the fascia is one of those structures that is always surprising how much force is actually going through that when you run, and you get different numbers depending on where you look, but it's an extremely large amount of force that's through there when we run. And we need to make sure that the exercises we're trying to do to improve that are challenging enough. And I think that's, personally, I don't know what you think about this, Josh, but when I see people who've made a mistake with a rehab with plantar fasciitis, they've just not done it heavy enough, or they've just not applied enough load to actually get that response. So if you've been doing, say, one of the classic exercises that people do for this will be like a heel raise. You might do it with your toes on a towel or elevate it in some way. If you're just doing that with body weight, there's a good chance that we're not meeting the demands of the running, but we're not addressing those demands in the rehab. We probably need some extra weight, extra resistance, however we achieve that. So yeah, I think that's the big thing, is that it's probably the rehab is underdone, and we maybe just need to look at how we're prescribing that.
Yeah, I smile because that's the thing that I see all the time. Now, I do understand that it's often really difficult for people to achieve that extra load, so body weight is sometimes all they've got. But a backpack with some books in it is better than nothing to get extra load. See it so much. But often it is really, if you're just experiencing plantar fasciitis now, though, that pain in the bottom of your foot, don't listen to this and then go straight for something heavy, because often doing body weight is a good place to start to settle things down. But it's really important to remember that when your symptoms have settled down, it doesn't mean that your structure is better. It just means you feel better. And often it's those injuries where you go, I have this and then it goes away, and then I have this and then it goes away. It's just because unknowingly you're doing 50% of the work to get it better. So yeah, that's plantar fasciitis. This kind of what you spoke about kind of brings me on to the next thing, where you said that the loads going through fascia are surprising. The same is with, somebody's asked about piriformis. Now I'm going to be cautious to give specific advice about piriformis syndrome, because it's questionable whether it's even a real thing at the moment. It's what the research is saying. However, when we look at the glutes, on running, the glutes can take, depending on what you read, between 5 and 7 times your body weight. So if you are doing rehab, classic rehab, which I will even prescribe at the start, things like glute clams, all those sorts of things, they are good to start off with, targeting that area. However, you might not be challenging yourself enough to get that better, especially if it's a recurring problem. That doesn't mean, please don't start going single leg squatting 6 times your body weight off the back of that, but get somebody to have a look at it and just see if there's a reason why it keeps recurring. Now, that may well be biomechanical. Again, I'm going to bring it back to that load versus capacity. There's some reason you're overloading that area, which is the reason why it keeps coming. That cover it?
Yeah, I think piriformis syndrome, like Josh was saying, it's a bit of a contentious one. It's quite often given a bit more of a broader umbrella term now, of kind of deep gluteal syndrome. It basically means we've got some kind of irritation in that kind of deep, in the gluteal area below your bum cheeks, basically.
Mm.
And exactly what Josh said, one of the most common reasons that those structures get irritated is because other more important muscles, stronger muscles, are not quite pulling the weight. So yeah, it just goes back again. Is the rehab actually addressing the problem, or are we just doing things that are, that might look good on Instagram? We always need to make sure that we're conditioning the body to deal with the demands of the run, really.
So somebody that comes to you with piriformis syndrome or deep gluteal syndrome, or even lateral hip pain or greater trochanteric pain syndrome, whatever it wants to be called, where you want to read it, those things that affect that hip area, would you stretch them?
Um, difficult to say for all of them because they're all very individual. And I think the main thing is obviously making sure we try and be a little bit more specific with what our diagnosis is. In a lot of cases, I don't think there's necessarily anything wrong with stretching. I just don't think it's probably the best bang for your buck in a lot of these cases. So if you've got a problem around the hip, like we've been saying all the way through, really, a lot of these issues are down to the area not being able to tolerate the loads that's going through it. Now, stretching is going to put load through that area, but it's only going to put quite a small amount of load. It's going to put the amount of pressure on that you can use with your own body weight. Like Josh had discussed earlier, it's multiples of your body weight probably going through these areas when you run. So if I was to pick, some additional kind of things for runners to be doing, I'd probably go more down the direction of strengthening these structures and making them more robust rather than trying to lengthen them.
Mm-hmm.
Does that kind of answer your point, mate?
100%. I don't really think you can get it really wrong if you strengthen something. I can't think of many conditions other than if you broke something in that area to go after strengthening. Even when something is broken or fractured, we strengthen it eventually. But to do some form of strengthening, I think is probably always in the answer somewhere. In fact, I struggle to think of a condition where it isn't in the answer somewhere if you come in to see a physio.
Yeah, I think it's always going to be a part of the rehab is just making the area robust. Obviously, there's things that can lead into that and reasons why certain things might get overloaded, or we might look above and below the area. But there's always going to be that component, isn't there, of just making things more robust.
Yeah.
While we kind of look for the reason it might be getting overloaded in the first place. That's something that we can only really do in the clinic. But I think, yeah, absolutely, it's a general rule. I think that's a good place to start.
So the takeaway from that is if you've had a problem for an awful long time and you've been prescribed stretches to manage it permanently, your stretches may not be doing what you think they're supposed to be doing or what you are using them for the intention of. So it may well be worth just getting that reviewed to see if there is something that you could be doing to be getting stronger. Next one is quite a specific one. I'm only going to touch on it. It's somebody with metatarsalgia. That's metatarsal pain in the base of the foot, at the base of the toes. There's quite a lot of variables to this, so I'm not going to go through it. But if you are watching this, whoever sent this in, I think a good place for you to start would be for you to come to our clinic at Chorley and have a go over our gait scanner. I think the more data and the more information we have to be able to help with this question specifically, the better chance we've got of giving you some accurate advice. I don't really want to answer that question otherwise. I've just had another one come through. Hypermobility in my joints. After a long run, my hip is a bit sore and stiff. Any advice?
Okay, so I think for hypermobility in general, it's probably not going to be a range of motion issue. So, like we said with the previous stuff, stretching and things like that probably aren't going to give you the best bang for your buck. I think if you've got hypermobility, which just basically means you've got a bigger range of motion in the joint, one of the problems that people tend to have is that they can't control that range of motion that they've got. So I think looking again just to look at doing some exercises where we work through the range of motion and look to get stronger in these kind of lengthened positions. Again, again, like with the metatarsalgia example, it's difficult to answer some of these questions without knowing the specifics, because there's often a lot of variables that go into this. But I think that's something that we could definitely help people with, and it's probably more a case with hypermobility of making sure that you can control the range you have got, rather than trying to make that any bigger or further stretch that. I think that control through range would be my takeaway from that.
Yeah,
what do you think, Jeff?
I actually don't think you emphasise that enough. That with hypermobility, going after because with hypermobility, often you inherently have more range than you quote unquote should have, or than the rest of us have when we compare to normative data. So it's imperative that we know that you've got control through that range, so that you aren't overloading certain areas which aren't designed to be loaded so heavily. It sounds very simple. Well, it's very straightforward, but it's not simple to figure out what it is that you need to do. But in terms of your answer, we need to just make sure you've got control, really, and that's the best chance we've got of keeping you out of pain for as long a period of time as possible. Finally, I wanted to touch on, because I see this quite a lot, and I know I've got a couple of minutes left, not many, wanted to touch on runner's knee or anterior knee pain. I just want to preface this by saying that the principles are the same. Any injury that you ask us about, the principles are going to be the same. If you're experiencing this pain at the front of your knee when you're running, then the things that we're going to go after first are technique modification, load modification, and letting things settle down. Tom, do you want to give us your view on runner's knee / anterior knee pain?
Yeah, so runner's knee, again, is a bit of an umbrella term, really. It just basically refers to any pain that's in the front of the knee. So obviously, like we've said throughout this, it's a little bit difficult when we've not got the specific, but as a general rule, what we're looking to do when we've got pain in this area is, first of all, find a way of modifying something so that the pain can settle down, and then we can look at in a little bit more detail as to maybe why the knee is experiencing more load than, say, the hip or the ankle. And that might be the point where we'd look at you run on the treadmill, or we'd do some kind of analysis to try and look at why maybe is that the case. And then going back to what we've said, throughout the video, when we've established that and we've made our changes, it's making the muscles that support the knee as strong and as robust as possible to make sure that the knee doesn't get overworked and angry. So that might again end up with you doing some kind of strength and conditioning work when we've made those alterations.
Yeah, absolutely. And I know you alluded before to the fact that a problem that you feel is often the result of a problem above or below the area that you are suffering from. So if you do come with knee pain, really don't be surprised if when we've assessed you, the majority of your rehab is around your ankle or your hip. Because from my experience, that's more often than not what is found, that the knee pain comes from the structures around the knee compensating and changing the mechanics from something else that isn't working. So, for example, not isn't working, but isn't pulling its weight. For example, often in females, we find that runner's knee is a problem at the hip, which is related to a certain movement which comes from essentially the width of your pelvis. So it comes from excessive adduction. I don't know if you find that a lot, Tom, that we have to look at strengthening those external rotators and the glutes, etc. But it's often, I rarely find it's actually a knee problem with this.
Yeah, I think like you mentioned before with some of the other examples, it's a bit of a trade-off, really. If we're looking at making technical changes, we'll be looking at reasons why the knees may be experiencing more forces than other areas, and see if we can shift that around for the time being. And like Josh said, one of the ways we might do that is change something at the hip. It can quite often be quite effective. So yeah, it's one of those things that there's sometimes a little bit more in the equation, but it comes back to the same thing. We're letting things settle down. We're looking at why they're happening, and then trying to make them more robust.
Yeah, exactly. So with any of these injuries that you do come to us with, and please do come to us, like I said in the last one, we do have these free 15-minute assessments where you're under no obligation. It's not a sales pitch. We're genuinely just trying to find out what's wrong with you and if we can help you. So if you do come to us to find out what's wrong, please don't be surprised if you come to us with back pain, we end up targeting something else. Or if you come to us with knee pain, we end up looking at something else and completely. And it kind of feels like, well, why are you looking at my hips when my back and my knees are hurting? However, it's just things aren't always as they seem with your running injuries. And if they were, it would be quite simple to fix them from Google.
Yeah, I think the other thing that what's nice about the free 15-minute assessments is it just the most important thing with managing any running injuries is finding what's going to work for you personally, and that's one of the difficulties with these videos is that it's difficult to come up with a one-size-fits-all because it just doesn't exist. So even if you just come for the 15 minutes, it just gives us an opportunity to learn what you're about and what you're trying to achieve from the whole process. Even that short amount of time will allow us to come up with a much more specific program for you that's a little bit more individualized, and can't really stress how important that kind of individualization is really. No two people respond to the same things in the same way. So yeah, if you've got an issue that you want to come in, you'd like some advice on, I think that's a great way to get in and have a consultation with one of us.
Yeah, exactly. And slightly, potentially even more importantly, is we actually quite enjoy doing these. Like, it's really nice to get to meet new people and see new faces and see if we can just see as many people as we can help. So yeah, please do go on the Summit website and just book yourself one with one of us, even if it's just a phone call. The more, because often being seen isn't as important as being heard. What we understand about your injuries often come from what you tell us as opposed to what we see. So if you're worried about the fact that even during this lockdown, you might not want to come and be seen face to face, a phone call is significantly better than nothing. So yeah, please do come see us, and I'll attach my email to this back for any specific questions. If I can help, I will do. Somebody as well asked, is there any general exercises people can do in order to reduce their risk of injury? Yeah, you can. I spoke about those in a couple of weeks ago. And also there's a program of 3 exercises, which is a decent warm-up, which people can do to very slightly reduce their risk of injury. But yeah, as a rule, try and train single leg. But just doing strength training with good technique is better than nothing. It sounds rubbish, but I think it's true. Tom, in a minute or less, anything that people can do generally to reduce their risk of injury?
I think the main thing without getting into too much specifics is just think about what kind of muscles are going to be involved in running. What are the main muscle groups that we need to work on? So really, really simple. I'd have one exercise in there that's going to train your calves, one that's going to train your quads, one that's going to train your hamstrings, one that's going to train your glutes. You can maybe add in a little bit of core stuff as well, depending on how you define that. But yeah, my approach is looking at what muscles are involved in running, what positions are they used in running, and how can we best kind of train them and without it taking too much of your time.
Yeah, brilliant. Well, I know you've got a patient coming, so thanks for that, Tom. I appreciate it. And yeah, just get in touch with any questions you've got. See you later.
See ya.